what I would like to talk to you about today is primarily some work on a review in the home care sector specifically. I'm going to start off, though, with a little bit more of the broader context with the work that was done that really, I think, pointed us as a committee to realizing that focusing on home care was definitely a key area for us to do so. So I would like to start the presentation with some acknowledgements rather than waiting to the end, because I feel that is really, really important. So I will do that in just a moment. As I'd mentioned as well, just the context, so a little bit more of the work of the Seniors Care HR Sector Committee, the HR strategy that we've called it, so a balanced review. I hope it's balanced from the many stakeholders and evidence that we look to. And then, as I said, of course, the focus on home care itself, so some findings and some recommendations for moving forward. So, acknowledgements. A thank you to everybody that's in this room. I hope that people have not been missed, purposely in different colors so that no one stands out larger than the others, but everyone from employers to representatives from health authorities, different ministries, and of course the frontline workers themselves, the unions as partners. I know we talk so much about a collaborative approach, but I think that's definitely something that has been seen throughout this committee. So a big thank you. This work, this presentation would not be possible without the input and the ideas and the passions from everyone that I have had the opportunity to connect with. So little bit about the context. So the Seniors Care HR Sector Committee was established under the Provincial Labour Market Partnership Program to oversee the development and implementation of the HR strategy. So definitely some great support from public funding, so that has been very helpful. The committee itself was comprised of industry, government, and union representatives. So again, I'll do the collaboration piece here. I think that really cannot be emphasized too much, just how important that has been. And the mandate is to understand the HR climate for seniors workers and develop strategies for, I think, for attracting the right people, essentially attracting and keeping the right people in the right roles. So very much the focus of the committee, of course, has been on the non-health authority employers, although there have been many opportunities for input from the health authority folks, so very, very grateful for that. Hopefully these ideas I'd say they have not been developed in isolation, but the focus is definitely much more so on the private and not-for-profit group. But I think just really, really important that as we talk about, home care and seniors care, that the mandate of this work is definitely around the recruitment and retention elements of the workers. So the HR strategy, hopefully they're effective strategies for seniors care workers moving forward. So I'd talked a little bit before, or just mentioned the idea of a balanced approach. So where the data, evidence, findings, etc. came from were from multiple lines. We started by looking through labor market analysis work that was conducted by HEABC. So some great focus on the quantitative side of things. So looking at vacancies, hard to fill positions, whether we're anticipating challenges in terms of recruitment or retention or both over the next couple of years and what that looks like. So it was very interesting to have some quantitative data to work with, and then conducting interviews with employers and with other partners, and also with frontline workers themselves. So there was an opportunity to really balance the numbers and the people side of things. So on a more formal sounding note, rather than the people side of things, actually did conduct an HR needs assessment, so very, very heavy on the stakeholder consultation. If you don't know already, you will certainly get the sense that definitely has certainly been, I think, my area of focus is really on the qualitative side and really listening to what people say that are doing this day in and day out. A best practice and literature review. Certainly look to some other jurisdictions across Canada, but I think so often I don't know that we forget or if we just want to look further afield, but there is some really, really great work that's being done across our lovely province. So had the opportunity to speak with some really passionate people, I think doing a lot of great work. And then some action planning sessions with some of the key stakeholders. I think what we wanted to do from the strategy right from the get-go is to make sure that recommendations were feasible and practical. They could actually be implemented in the climate that we're in right now, and that there was actually a hope that some of the good work from the recommendations could be sustained. So all of that was thought about ahead of time, and again, some really, really great sessions and some really, really good feedback from our committee members. So a little bit about the numbers, so the relevance and what the evidence tells us. So the sector employs a total of more than 14,000 British Columbians in the three main occupations that we looked at. So this is resident care aides, licensed practical nurses, and community health workers. So we're certainly not dealing with a small number of people that stand to be impacted by some of our strategies. I think it's also really important to note here, too, that 94% of BC seniors are living at home. I'm not sure the order from all of the presentations, whether there's been much discussion of that yet or not, but I know in some of the materials that I scanned through in our packages, I thought, okay, this is good. My numbers aren't lying with some of the more up-to-date information that's in there. But I think really important to know that across Canada, BC actually has the highest percentage of seniors that are living in their homes. So this focus is clearly very, very, very important. And again, just a little bit more of the relevance, I think, or maybe the impact of the work that's being done by these caring people going into seniors' homes every day is that 33,000 clients in BC received over 8 million hours of home care services. That's a lot of time. What we found from going through the quantitative information prepared by HEABC is that there definitely seems to be a sufficient supply of LPNs, care aides, and community health workers, but the biggest challenge is actually with retention. So it's one thing to find people, get them trained, get them in jobs, but are they entirely the right people? Is it the right environment for them, and will they actually stay? So employers that were approached for the survey noted there were some significant challenges with retention for these three key occupation groups. Definitely saw a lot of issues in terms of turnover and what that means to organizations, and eventually, of course, how turnover stands to impact the seniors that we're actually aiming to take care of. So retention problems definitely are greater than the recruitment problems, and you'll certainly see that as we go through some more of the strategies and findings, that the focus is very much so on the retention side of things. And also the expectation that retention of casual workers will continue to be more difficult in the next couple of years. I mean, I think we all know a lot of the issues in terms of being able to retain workers, funding, et cetera. And so the reality is that there is definitely a strong reliance on casual workers. So a little bit more about what the environment tells us. So a little bit around some of the sociodemographic factors, and I'm sure none of this is actually new news to so many of you that are working in this. But seniors population is on the rise. This we know. We're very aware of this. There is also a reduced availability of family support and other informal caregivers expected over the next few years. I think some interesting information and stats out there as well, talking about the average age of those people that actually tend to be doing the caregiving themselves. They certainly are not getting. Well, none of us are getting any younger, but they're certainly they're not getting any younger themselves. They're continuing. There's a lot of seniors themselves that are doing a lot of this work. So I see some nods, which is always good. Seniors are increasingly looking for quality and choice, and it's almost up here as a bad thing because it's a challenge. Clearly, this is a very, very good thing. I think all of us are being encouraged to be, active in our own care and partners in our own care. All of these great terms. So, really good stuff. The more I think information and knowledge that we're sharing, it means that people are acting on it. They want choice and they want quality. And I think we often focus on safety as that one aspect of quality, which clearly is very, very important. But I think some of those other dimensions in terms of satisfaction with the quality of services, I think is increasingly very, very important and definitely on people's radar. Also, as our working age population shrinks, so will the availability of public funds to certainly help cover the cost for a lot of this care. Some technology factors. So technology is a good thing, but it does make for some challenges, I think, especially for those working in home care environments. We're often noticing that technology is being used, whether it's instead of or whether it's really the intent is to enhance communication. We do often find that technology is the biggest vehicle for communication with a lot of the community health workers, rather than that face-to-face interaction, which I think we would probably all agree is favorable if it's possible. Political factors, of course. So definitely, as always, there's an increased pressure certainly on limited funds, and definitely a need to explore some alternative options. And also, I think the expectation that the private and the not-for-profit employers can actually do more with less. Can they, can't they? We don't know. And maybe that's the million-dollar question with some of the contracted services, and I'm definitely not going to get into that. And just also a little bit more on the economic factors. So obviously, healthcare costs are more than the amount of dollars that are available. So where do we focus our efforts? A friend of mine, when I'm having a little moment about woes in life, as we all do, always says to me, you can have it all. You just can't have it all at once. So maybe the same thing applies to us here as well. But all of this means to say is that without sufficient funds, again, we look to casual employment, and anytime we see that so much, I think there is definitely a lot of turnover. So this lovely diagram is really meant to show, I think, essentially the ripple effect. So there is not enough funds. We're expecting people to do more with less. There becomes issues. The question is, are we actually getting as much value as we're hoping to? So the cost of the turnover to employers, there's always studies done in terms of trying to actually quantify what the cost of turnover is, but I don't think that's not my area of focus or expertise for that matter either. But we do know that a lot of money is wasted. You don't keep the right people, you keep trying to find them and retrain them, and on and on and on. So really the impact, again, is care to seniors. So that's something that obviously we want to avoid the turnover as much as possible. So all of these findings went into the creation of the strategy. So again, looked at the quantitative data. What do the numbers tell us? What does the evidence tell us in terms of retention and recruitment problems? We know the focus is on retention. So taking the numbers, taking what we heard from experts in the field, including frontline staff themselves, I think for fairly simple areas of focus. The first being planning for the future with the right partners. Also using data, using evidence. So the work that HEABC did was fantastic, but that's not just a one-time thing. That is something that would be repeated into the future. I think we do need to look to evidence to make sure that we are still continuing to focus on the right areas. Attracting the right seniors care workers. So yes, I did say been emphasizing so much that the retention is the issue, but we still need to focus on actually attracting the right people so that they stay in the first place. So are we communicating, is it really transparent when we sell these programs to people? Do they really truly know what they're getting into? Ensuring that seniors are engaging, seniors care workers in the right way. So we've got them and we want to keep them, but do we tell them that? Do we engage them? Do we appreciate the amazing work that they do every day? And ensuring that sector employers also have the right knowledge. Now I know up here it says sector because of course that was the context of the work that was done, but I think this really does go across the board. Regardless of what kind of agency you're leading, you're working in, we're still providing care for BC seniors regardless of how the money ends up coming or looking like. So some great achievements actually have been accomplished already, which is really nice. It's actually very, very nice. It's actually quite rewarding to get to stand up here and say, did some great work, spoke with some people, came up with a few good ideas, but now I can actually present back to you some of the work that is already underway, which is great. So, proclamation of Seniors Care Worker Day. So this is in October 18th, I believe, which is actually really exciting, I think, to have a day that recognizes people that are doing this incredible work. So I think that is a great achievement. Some pilots underway looking at responsive shift scheduling, so having an opportunity to ask the people that are doing the work, and very simplistically, what hours would you like to work, and making it work that way for them. And I will emphasize it is very, very, very oversimplified. I know that. Increasing the profile of new Canadians that are employed as care aides and community health workers. We have some amazing people that come to our country and to this province and are fulfilling roles in providing care for seniors in their homes. So really, I think really emphasizing and recognizing some great diverse skill sets that we have. So some great work has been done around that. The home care scheduling review. So in that first piece of work that was done, it became so obvious that retention, especially in the home care area, was just a huge area. So I will be sharing those findings with you momentarily. And also the development of a sustaining body for this HR committee. I think it's really important to mention that. Oftentimes, money flows through, people get together, sit around a table and come up with some great ideas, and that's that. But I think this is actually a great approach where the work that is being started and carried out by this sector actually can continue, which I think there will certainly be some discussions on later. So it is evolving into a safety committee, so obviously a bit more of the focus on the safety side of things, but I think it's really important to be able to see that. So the home care review itself. The purpose of the home care review, when we realized that the numbers were saying, yikes, retention is just a huge issue. The turnover and the use of casual employees in the home care setting is just so high percentage-wise. Thought, okay, let's analyze the feasibility of some alternative scheduling models for community health workers. So how can we essentially keep community health workers a little bit happier in their roles? The scope and the focus, however, was adjusted quite quickly. So it became really clear that doing pilots in, cluster care kind of work was not at all the right way to go. So where cluster care is working, it is working, it's being done, and lovely as it is, it isn't actually anything that is deemed as particularly an innovative model anymore. So we found that stakeholders were really revealing more critical issues. So the simple issues, the foundational issues, and the ones that really, given my choices, it would be much easier to say out of scope. However, we quickly realized that basically everything was going to become out of scope if we didn't actually address these issues. Fixing them, I suppose, is definitely a different story. Lack of data to actually support some of the new scheduling models. So again, there is some great work that's being done out there. Some of it's anecdotal, some of it's a little bit more informal. However, actual evaluation data is really lacking, which is too bad. It would be so wonderful if going forward pilots could have that evaluation focus up front, so that we I see nods. Thank you. we know we're trying to do really good work. We want to improve care and make our workers happier, but those are so big and so lofty that I think we need to break that down into something that's a little bit more tangible and a bit more manageable. A way to also track success and see what's working. So system-wide issues as huge barriers to moving forward. We don't have enough data out there to support whether certain scheduling models are actually working or more effective than others, and hence the uncovering of these systemic issues. So spoke with home support representatives. So again, frontline staff were very much involved in this. Decision makers, schedulers, the union representatives, and the health authority and ministry reps as well. So, really wanted to find out from people, what are their objectives associated with scheduling? It seems so simple. You've got seniors that need care, you've got workers that are going to provide the care. I know that we all know in this room that it is so much harder than that, but really what are the objectives? What are the challenges? What are some of the things that people have done that is helping to overcome some of the challenges? So first of all, I think we've definitely covered this part off here already. I know I've emphasized it probably too many times about the casual workers. So they are definitely being used to absorb fluctuations in client demand. So I mean, obviously situations change. Sometimes seniors end up needing to go back to the hospital, and the need for the care in their own home changes, etc. So this emphasis on the casual basis. For these workers, there is no guarantee of number of hours each week that you're going to work. So my gut is probably for most of us in this room, we think, oh my God, there's never enough hours. I'm working so much. Life is crazy. But you know what? For these people that are coming into seniors' homes and providing this care, the fact that we can't actually say you will be making this much money on a weekly or a monthly basis is pretty stressful. I think definitely subjected to some unfavorable and pretty unrealistic availability expectations. I mean, do you really want to be available from 7 in the morning until 10 at night? Probably not. Definitely, I think safe to say, and this is painting a bit of a negative picture, and it's really not meant to. But I think this is the reality. Not in all of the cases, but I just think that it is important to present this. So I think overall it appears as though there's a low level of commitment from employers. There may not be at all. I don't think that is ever the intention, but it certainly comes across that way to a lot of workers. Having to check in sort of on their own time, own expenses, etc. And the lack of confirmation of hours and work is definitely a huge challenge. So a nice little slide that some of you have seen probably many times by now, but simplistically, why community health workers come? What attracts them into the role in the first place? So termed it as a low barrier to entry. The programs are fairly short. They're pretty inexpensive. It's marketed as, take this program, there'll be employment for you. Why they stay, I think this is the interesting part. So relationships with clients. Every single community health worker that I've ever spoken to, they talk about the hours and some of the challenges, but they spend about 10% of their time talking about that, and the rest of it talking about the rewards and how much they really enjoy their jobs and the relationships with clients, and that's where they really focus their efforts. For many, certainly enjoying the independence. I know always pros and cons to every job, but some definitely talk about enjoying the independence of the work that they're doing. And why they stay, again, I mean, they depend on pay and benefits, particularly for those that are in regular positions. So why they go? There's some great sort of models and ways of numbers are always fun to play with in terms of interpreting data, but you can ask people, I think, what some challenges, and very interesting in speaking with a lot of the frontline staff. There's a lot of challenges and frustrations. However, they'll still stay and kind of keep working with it. But the really big ones in terms of why they actually leave is the increasing expectations without compensation. And the involuntary loss of hours, and probably one of the biggest things is leaving to actually move into the residential care area rather than home care. So all of this to say is, no matter which perspective or which group of people you speak to, the good news is that all of the stakeholders have actually said, scheduling of community health workers is a top priority for us. So challenges for employers, though, certainly around providing sufficient hours. So it's one thing for me to stand here and say, oh, it's really terrible, we're not giving enough hours. But on the other side of things, employers are struggling, trying to find a way to provide hours for all of their workers in a way that meets client needs, union regulations, etc. So community health worker challenges, definitely the work-life balance and asking for more consistent schedules, of course. And for unions, definitely support and their role of supporting their members. So the good news is everybody agrees that this is an issue. So what I've put up here is I've called it a pathway of some of the systemic issues. So this is my thoughts, perceptions. I am very open to some further ideas and questions. Would love to hear if people do agree with this. But I really feel like one of the biggest issues is that there actually is a very low profile of home care. It is definitely it's the lowest on the list, which is so unfortunate because we know our population's aging. We know that seniors want to live in their own homes. They're being encouraged to. I mean, some of the health authorities, I know there's the home, I think it's Home is Best from Fraser Health. I hope I said that right. And I know that there's certainly some other initiatives from across Canada. So the numbers are telling us that seniors are living in their homes. There's going to be more of them, and they need caring for. But sadly, home care is just not looked upon very favorably. So I think that's the biggest issue from the start. Some funding and performance expectations. So I'll cover that in a minute. But I mean, I think definitely there's always issues. There's funding coming from the ministry to the health authorities, and if it's to contracted service providers. So I mean, there's contracting issues. Are we paying by service, by task? And there's a lot of sort of this. I think it may actually be a lot clearer than we think it is. It just doesn't seem to be all that clear, although I'm seeing a nod saying it's actually not clear. Good, I haven't missed something. The third challenge is around client expectations. So I just had a nice little rant about how we should actually, it's a good thing that we have really high expectations and we want quality service, but what this obviously means is higher expectations, so we're actually looking for more and more and more. Then another challenge is this polarization of client hours. So we're trying to schedule community health workers in ideally a 8 to 10 hour period, but yet we know that the majority of seniors for the care, they really need the hours in the morning and the afternoon. That's the way it is. It is quite polarized and makes it very challenging to actually have a very consistent schedule throughout the day. Another challenge is the complexities of scheduling. So it isn't just about matching workers to clients. There are so many more complexities that we'll get into in just a couple of minutes. And then also this challenge around actually reviewing scheduling pilots. As I said, there actually isn't, at this point, there isn't a lot of data that is available. I have no doubt that there is data being collected and some great work being done to try and figure out what's working and what's not, but sometimes it's not always appropriate for data to be shared, or maybe it's just not quite structured enough quite yet. But those are really the main challenges, I think, that have been identified from this work. So I'm going to go through them individually just in a little bit more detail. So around the lack of a positive profile for home care. So home support, it's not seen as a career of choice. Residential care is definitely seen as more desirable. I think we can all agree that home support is vastly undervalued. It really is. Whatever perspective you're coming from, it is really undervalued. So really, it lacks that competitive advantage. We don't have the funds and the resources to pay people very, very well for this work. So a great quote, I think. For some reason, even though community health workers need more maturity, discernment, decision-making ability, home care pays less than residential care. It was really interesting as I was finishing up these slides the other night. My mother-in-law was over, and I asked her to have a wee look for any typos. So if there's any out here, it's her fault. And of course, it's not. Anyway, she was reading through it and said, "Oh yeah, exactly. A friend. This is on the island." And she said, "Oh yeah, a friend of mine used to do home support, and she's so happy now. She just got a great job in residential care with the health authority, and she's so happy." And I thought, wow, yeah, this is kind of one of the main issues that we're dealing with at the moment. Funding model being at odds with performance requirements. So I've definitely found this issue to be a bit of a challenging one and a bit of a sticky one, and I almost didn't want to go there for fear of entirely saying the wrong thing or alienating different groups. But from what I could find is the following. The client fee structure is applied on a per diem basis, but yet reporting continues to be based on service hours. So we've kind of got this whole, is it a task that people are being paid for? Is it hours? How does the funding really work? So from the ministry to the health authorities to our contracted providers, how does it really flow through? So is funding being based on this kind of a criteria, but yet reporting is being based on something else? This is what seems to have come out. Whether there's misconceptions or a lack of communication, I think that's probably just as important as if there is a huge issue. But there is definitely I think safe to say there is definitely some frustration from employers trying to provide services and match different expectations in a way that seems to them to be fair, certainly as far as the funding arrangements goes. These performance-based contracts, of course, with the contracted groups, again, found some frustrations. I really do feel that a lot of it has to do with possibly with a lack of communication and just an opportunity to really discuss what's going on. This continuity indicator came up many, many, many times with employers saying, this is crazy, this just doesn't work for us, it's absolutely impossible, in face of union requirements, for example, and then heads butt, and you just really never move any further. So I wish that I had a magic solution. Sadly, I do not. I guess the biggest thing I can do is share the findings, obviously, from the different groups that I have spoken with. And I guess the question here is communication between contractors and employers effective? I don't know that it is. And again, I think I really have to emphasize that it is not from a desire of wanting to work together. I just think that there's some really different perceptions that are going on, and hence this being one of those systemic issues that is definitely not an easy one. A note also about case managers, and so the case managers with the health authorities obviously are that first line of, that first communication with seniors and with their families and letting them know the type of services that they can expect to receive. So providing current information and really realistic expectations with clients and families is obviously very, very important. Again, this seems so simple. This doesn't seem like anything new or anything that's really fixing the issues, but this is definitely an area where I heard from people repeatedly that there is an issue with clients either being told something or clients having that expectation that perhaps just wasn't communicated, that things have changed a little bit over time. And I think one of the big things here is for the caseworkers to really let clients know that they're receiving care. They're receiving care for whatever it is that they need. They may not be receiving care at exactly 8 a.m. in the morning, but they will be receiving that care throughout the day. Again, so simple, but I think we see that these are some of the issues right from the start that definitely impact the workers and scheduling. As I mentioned, so demand for client care is definitely heaviest in the morning and then in the evening. So if we have 60% of the work being in the morning and 30% being in the evening, clearly we know that this makes for some pretty significant challenges with respect to scheduling workers. So the impact, shortage of work hours during the day, the need for split shift requirements, and I know for some people that is not a negative thing. That actually works really, really well for them, but definitely a need for that. Some issues in terms of work-life balance if you're really actually trying to be available all day long. And of course, as I have up here, so the block funding model I think does pose some challenges in terms of actually balancing worker and client needs while being able to meet a bottom line. So to accommodate client and worker needs, I think a couple of great options that are up here. Obviously, one size does not fit all and does not work for everyone, but a couple of different ways of looking at scheduling is split shifts. So exactly as it says, so somebody would do some work in the morning and then later on again in the evening, and that does work well for some people. Definitely, that wouldn't be the choice for all, but it is one model. And fixed hour pilots, which I think certainly would be a little bit more appealing to the majority of people. So where they actually would be available for or would have work hours for a fixed amount of time. So shortening that window of availability, which I think we could all agree certainly would be is beneficial from a worker perspective for sure. So I've mentioned a few times that scheduling has become more complex. So starting at the bottom here, we've got in its most simplistic form, we're matching workers to clients. As time has gone on and the environment and some of the issues are what they are, we see that scheduling is a lot more complicated than that. So there are often contracts with health authorities to manage looking at worker sick time, for example, injuries, vacation, life. Sometimes your pool of people changes. labor regulations, collective agreements, and then of course employers certainly have some of their own policies as well. I think that one probably falls so much lower on the list with some of the other huge challenges, but still, so we've gone from something fairly very simple to, you know, looking at this complexity. Then we also are trying now to, you know, to actually match workers' attributes and preferences in a controlled, unionized environment in a way that really fits with what seniors want. So senior A is really looking for worker B, and you tell them, I'm sorry, this actually can't happen. So there we see that relationship piece breaking down, which I think we all would agree is so very important. So some huge challenges. So everybody agrees, another agreement is a good thing. So we know there's a lot of challenges, and everyone agrees that there is definitely a need for more training. So the way I've painted the picture, it probably sounds as though there actually isn't a whole ton of hope, but I hope that's not the case. I do think that there actually is a lot of hope, and I think that I think some really good opportunities exist for some training opportunities too. So what is required is an aptitude for working in a fast-paced environment, managing multiple priorities within a constrained environment with competing demands. So I don't know about you guys, but I'm not sure. I'm not sure that I particularly love the sounds of that description. But joking aside, that is what we need. That's the kind of person that we're looking for, somebody who's dynamic with experience, can just kind of manage all these balls in the air. However, we often know that for schedulers coming into these positions, oftentimes they don't have the experience or the training to really help to support them be the best that they can in their roles as well. So there actually isn't a formal scheduler training program. Most employers, and I think health authorities, of course, do spend time with those that are in those roles, but I do think that having a more formalized type of a program or training would be very, very beneficial. And I think one of the bigger things is the practical side of things. There's definitely scheduler training. There's a lot on the technology side. This is not about software training. This is really about being able to systematically navigate through a lot of the competing priorities and demands. So in speaking with some of the schedulers, a lot of them actually volunteered this idea themselves and said, I actually would love some more training. I would really like to know how to be able to do this better, which is great. It's not those of us thinking, it's not myself thinking that I know what people are looking for. They have actually come out and said, I would really love to have this. And again, the nice thing is that has been very much emphasized with the employers as well as the community health workers. I think I've talked about this one probably enough here already, but again, this lack of a systematic approach to evaluating pilots. So there is room in the collective agreements for some pilots to occur, which is great for around the fixed hour positions and split shift and reduced hours. So this is definitely a good thing. I think we just really need to make sure that there actually is some data being collected on this. So as standardized and systematic kind of data collection as possible, because as it stands right now, a pilot finishes and there appears to be no clarity on what next. So you've done something, it's worked really well, can you continue, can you not? Where does that leave employers? Because those that I've spoken to have said, yeah, it was great, it worked out really well, I loved it, but now what? I'm actually really not sure what we're supposed to do now that we've finished this. So the recommendations, again, lots of issues, and I say very, very sincerely that there is nobody that I've spoken to that doesn't seem to care about it or want to try really hard or is open to, on top of everything else they do, to try and have a look at this. So recommendations, I feel, are quite simplistic. Improving the profile of home care, aligning further communication about client expectations in the sector with recommendations from the Ombudsperson report. I think that's really important. That's out there to to leverage that. Providing a summary of findings to partner organizations. This seems so very basic, but a report's been written. Now what? I think there are some good findings in here, and again, would love some feedback if anything really is off the mark, but I think it is very important to actually share this information with those people that have been involved. And last but not least by any means is a training program for schedulers. So again, it is very nice to be able to stand up here and say we actually have already started doing some of this work, which is great. So as a part of the sector committee, there are a few subcommittees. And that was purposefully done to make good use of everybody's time, not just for more committees. So we have 3 committees. One is looking at communication, so this is really around attracting the right people into the sector. Another one is focusing on some issues in residential care, around a mentorship program in particular, and the home care subcommittee is looking at a few key recommendations. So the first one is a home care summit that we are hoping to do in October. So the timing would also coincide with our seniors care worker day, which is done, of course, purposely. So the idea of this home care summit would be to bridge some of the public and the sector challenges, knowing that obviously there are some different issues, but at the end of the day, I think there is obviously a lot of similarities. So to bridge this by developing a more prominent voice for home support, working through some of the underlying perceptions and misconceptions, I think, that are out there. In what I've put up here is in a non-bargaining or negotiating climate, so in a way where the issues can just be talked about. And increasing the profile of home support through collaboration. Again, I'll have a little emphasis on collaboration there through key partners. Obviously, no one individual or no one group is going to ever accomplish any of this stuff. This collaboration thing is really, really key. So again, I mean, I think distinct issues obviously do remain between the private and the public, but where there is an opportunity to bridge some of these common issues and work together, I think that's when we will have an opportunity for that united front, and to really encourage people, I think, to come into home care and stay in it if it can be an environment that is looked upon a little bit more favorably. Participation, so these are just some groups up here. I really hope no one's been missed. But obviously from the employer community, different associations, the unions, decision makers, health authorities, those involved in training, and the very, very 2 important ones is the workers themselves and clients and families. I think having those voices is very, very important. Next one is a scheduler training program. So very, very happy to acknowledge funding from the Joint Community Health Retraining Fund, which is wonderful. So with funds from this group, we are about to start a scheduler training curriculum. So what will happen here is some curriculum is going to be developed for schedulers to actually help them dealing with some of these complex issues. So navigating the collective agreement and all of these kind of issues, and funding and expectations, etc. So schedulers can actually do the best that they can and be set up for success, which is obviously then going to impact the workers and hopefully trickle down to the most important group, obviously to the clients, patients, and families. So they very simply here again as well. So an opportunity to find somebody who will be developing the curriculum for us. And we've decided to use the model of training some super users or super trainers, whatever term we want to use for this. Obviously, this is to be cost effective. There isn't an opportunity to actually train everybody out there, but we're starting with the sector employers with their involvement. But this certainly will be open to schedulers in the health authority environment as well. So I do think this is very important. So opportunity for the schedulers, there are super users to then train others in their organizations. So really about building that capacity internally. Perhaps I'm shooting myself in the foot being a consultant, but you don't want to be relying on that outside person coming in and trying to troubleshoot. I think it's really, really important to build that capacity internally. And here the account of key findings to partners and key stakeholders. So, again, report's been written, great consultation, ideas, suggestions, but so many are not within scope, certainly of this committee. As I said several times, they definitely cannot be done alone. And I think just most importantly, a lot of the findings, they are beyond the scope and the mandate of the committee. So it's entirely inappropriate to suggest to our friends at the ministry and the health authorities, you need to do this, this, and this. My hope is that findings can be shared, and really this can be used as a tool to increase some communication. So again, implementation definitely residing with the key stakeholders. So some topics around role clarity, communication, so this case management piece, and contracting versus hours, and expectations on specific performance indicators such as this continuity piece. Also provision and account of findings to HEABC and the Community Bargaining Association as well. So, there's been ideas that have been brought forward and raised. It is absolutely not the committee's role to be making these recommendations, but I think to be opening those doors and working together collectively on it. So, some final thoughts. Home support, it is fragmented, and it is continually faced with a lot of challenges from differing perspectives. We know that there's some funding and performance requirement structures that make things challenging. Understanding of the collective agreement language. It's obviously it is a great tool, but it is also, I think, complex and can be challenging to navigate. And definitely this need, I think, to really use evidence to drive improvement. I'm the first person to say I'm a fan of the gut feel and just sort of what feels right, but I think we need those numbers behind us. We really do need evidence. And the key lever for change, I think, definitely the high importance on improving the scheduling situation for community health workers that I did hear from everybody across the board. So again, collaboration is key. You will all be having nightmares of me standing up here ranting about this, but I really do think that collaboration is so important between these key groups. So between industry, labor, government, education. I think we've seen it. I think we've actually seen some of this collaboration with this committee, which is great. Definitely commitment from our sector employers and from some of these other groups, really to I think invest in trying something different and invest in trying to make changes. And again, that these recommendations alone, no one recommendation alone or one person or group alone is going to improve the situation. My hope is that sort of this combination of the recommendations is that certainly will. So a nice little picture up here. So planning together, investing, changing, and evaluating. So again, this evaluation piece, it's great to have these new ideas and try something, but is it really working? Do we actually know what success? Do we know what we're looking for? What is success to us, and how do we know if we've actually achieved it? So my true final words here is obviously we know that turnover in residential and home care is impacting the cost and the acceptability and the safety of seniors' care. Worst case scenario, that's what we're looking at. Also, best case scenario, I think we can hopefully use this as a bit of our vision and reason for focusing on this work so much, is that the work that our workers do is obviously it's impacting our seniors' care. That is the reason, I think, why we're all in this room. So we need to attract and keep the right people in the right roles for seniors. And I guess the question remains, do we value our seniors, and do we value our workers enough to actually change some of our values and change some of our priorities? So thank you very much. It's a lot of talking at people. Would be very, very open to any questions and comments. Thank you.
It was very nice to listen to all the symptoms, but I'm sure that really what we have to deal with is the problem. And the problem is really underfunding. If you look at the countries where you have good home support programs, they spend more, just about twice as much as we spend in Canada on seniors' care. And that is really the question. You're not going to get top people to enter if they have to work split shifts and basically not much more than minimum wage. That reflects itself in the quality of service you receive. In regards to scheduling, that's a money issue too. Because what the complaints we have is that quite often in 1 week you have 5 different care workers coming in, and they're of different nationalities, and nothing is more unsettling on seniors than having to deal every day with a stranger. I think what has to happen is we have to basically say senior care deserves more money than it's getting presently now. And the other funny thing is the countries who are spending twice as much on seniors care than we do don't spend any more on a total health care bill than we do. As a matter of fact, they spend less, and the outcomes are just as good. So it's not a question of money itself, it's a question of priorities and allocations.
Thank you. I agree. If I could change things, I would, I can assure you.
Hi, I'm Susan Brown. I'm an administrator of community programs for one of the health authorities. I came today because I have recently took over community care as part of my portfolio about 1.5 years ago, and I'm on a real learning journey in this area. My experience is more with prevention and promotion, so it's been a big switch, early childhood to seniors care. One of the things that I have found listening today is that we keep talking about home care as if it's one thing. And then I'll see somebody talk about home care and they're referring to home nursing care. And they'll refer to home care and they'll talk about it as home support. And they'll talk about it as activities of daily living. And I think one of our challenges when we talk today, I've heard people say, you know, following the Romanow report, that they based it all on short-term acute care, home care services. If we're not clear in the language that we use, then the politicians are not going to be clear in what they hear from us. Semantics is really, really important. If we want the government to respond, we need to talk in their language. And so often we end up talking in our language about what we need. It was talked about today that we need to talk about needs and not solutions. Home care sounds like a solution. It has some limitations to it when we just talk about home care. It doesn't talk about the fact that what we really want is to promote the independence of seniors in a continuous way and looking at an array of services that's going to support that to happen. So I just wanted to share a little bit of an example from early childhood. Having been involved in public health for over 30 years, often we were frustrated that there was a lack of political vision around what was happening with early childhood. About 10 years ago, there got to be a real big focus on it. So what changed? One of the things is that we started having people talk about the economy, the economic model of early childhood. So it wasn't people working in the field. It wasn't even the parents or the clients of children or working with children. It was economists, people who spoke from the banks, from major policy areas that said this makes economic sense in our community. And because when they hear it from us, they go, yeah, you know, you're in the middle of it. You just want more funding for your area. It needs to be somebody independent that gives some voice to it. The other thing they did is they brought in people to talk about it who, again, were outside of the field, but were famous faces. Rob Reiner was one of the ones with early childhood who did a lot of focus on this is what works, this is, you know, where we should be going. And the other thing is that they stopped focusing on why we should be doing, you know, all of the problems with it, and they started focusing on the successes. This is where it works. Look at this model. It's working well, and can we duplicate this? So when you start putting all of those things together, there became a groundswell of interest in early childhood development. I think we have the same possibility with seniors care, although I do have to say, as an administrator in a health authority right now with responsibility for all community programs in our area, the area that is getting the most funding is community care. just wanted to share those thoughts.
Thank you so much, Susan. I know when I met you just very, very briefly sitting at the table there, I really liked your focus on when you said about looking at some of the best practices and what's working. And I know I had a conversation with Anita the other day, and we're talking a little bit about I think sort of the focus on appreciative inquiry, focusing on, I guess it's sort of you focus on what you want more of, right? Essentially, focusing on the positives, because it's true. We look at the challenges, we look at the issues, but I think maybe we think that we're shoving it under the rug if we look at just the good stuff, but perhaps we'd be actually doing just the opposite. Thank you.
That was a wonderful presentation and a tremendously important study, so thank you for sharing that. My name is Vicki Scott, and I work with the BC Injury Research and Prevention Unit, and I have a position at UBC School of Population and Public Health, the clinical associate professor, and a few other hats, but I won't go on. But the work we do is on fall and injury prevention for older adults, and a study called Strategies and Actions for Independent Living, or SAIL, has been piloted in BC very successfully for a number of years, and we've just received a new grant from CIHR, Population Health Physy Grant, Partners in Health Systems Improvement, along with Linda Foley, my co-lead. Is Linda here? There she is. Oh, Linda. Sorry. You do that, yeah. Different outfit, and that's, they do it all the time. And anyway, we're very excited about this grant. But in our prior work, we worked very closely with the community health workers. And they are the salt of the earth. They are just tremendous people. They are dedicated to their job. Along with Joni Sims-Gould from the Center for Hip Health, we did a qualitative component where we asked them, after they received the SAIL training, which is very much based on behavior change and communication skills and motivational interviewing, they reported tremendous job satisfaction improvement after that training. But one thing they also reported, and the health professionals were also interviewed in focus groups, and they confirmed this, there was tremendous increase in team, feeling part of the team. And I didn't see that in your findings. And I just wondered what you thought about that. Just having a role that's integrated into their job, that's based on some sound training, just gave them that team membership where they felt they had an important role to play and they would communicate much better with the health professionals. Did you find anything similar? Yeah,
absolutely. In the first report that was looking at actually developing the strategy before we started focusing on the home care so much, yeah, definitely. And it was through focus groups and some one-on-one interviews with workers as well, and they talked about that. And I'm racking my brain, trying desperately, and I can't think of the terminology. A workflow. Is it a workflow position? I hope. I see nods. Good. I think that's right. And the idea behind that being that a community health worker would actually have not a supervisory role, but there would be an opportunity, say at the start of the day, or where we see that maybe in some of the cluster care, where the team, so that they actually are a team. The community health workers in an area come together and have exactly that, because that. I mean, the benefit of saying people enjoy the independence, great, but the obvious downside is not having that. I think that is really tough when you're working by yourself. So I hope I answered your question in a roundabout way, but I have seen that done, and I think some really great best practices showing the value of that, and more of that individual, or more of that face-to-face rather than just sort of the technology, the BlackBerry text, you're going here, you're going there. I think that's so important.
Great. Well, we're just launching a 3-year study, the CIHR study, so we should talk, because there'll be a qualitative component where we could ask some more questions and learn more.
Absolutely, yeah.
A lot of overlap.
That sounds great.
Thank you.
Fabulous, thank you.
As the time has gone on, Canada has become much more diverse linguistically. A lot of clients you probably come across who don't speak or understand English, and there's such a diversity, people speaking Chinese, other languages. You didn't touch on how do you deal with that. So it's not only a turnover of workers generally, it's also a question of matching the workers so the client and worker can understand each other's language. And then there also may be other aspects of culture which you'll find different in a home of a person who's coming from a different background than the normal that you used to see here.
Absolutely. Thank you so much for bringing that up. That is clearly very, very important. Again, also in that first piece of work, that issue absolutely did come up from the preference of some. I think we try so hard to be very very sensitive and appropriate in what we say, but the bottom line is that some seniors would prefer to receive care from often from somebody perhaps of the same cultural background. That absolutely did come up, and where I mentioned that in that slide around the complexities and the challenges associated with scheduling, that definitely is one of those. So where I talk about matching workers to client preferences, that absolutely is one of them for sure. And I'm very, very well aware that it certainly goes both ways. I mean, communication. I've talked and said so very much how important communication is, and if you're not able to understand each other or perhaps see eye to eye, that is a huge challenge. I don't have the answers for how to do that in a way that is seemed as appropriate and seemed as okay, to be very honest. But I know that issue absolutely did really did come up in that first report, as I'd mentioned. So thank you for bringing that up. I think that is probably one of those issues that we shove under the rug, perhaps for fear of maybe saying the wrong thing. But that is going to be increasingly important. So where we talk of training and I think really leveraging skills of new Canadians, I think that's something that should certainly be really rolled into some training as well, so that there's, I think, clear expectations and that going forward. So thank you.
Is it reflected in your findings?
Not in the home care report, not in this particular one, but it is reflected in the first report, in the HR strategy report. It absolutely is reflected in there. Thank you.